Can everybody hear me okay? I think so. I can hear my own voice. Good evening. It's nice to see everybody out here tonight. My name is Dr. Benjamin Gielda, and I'm a radiation oncologist here at Spectrum Health Lakeland. This is Dr. Elizabeth Jeffers. She's the director of our breast program leadership in a group of which I'm also a member. We both have no disclosures to report, unfortunately, even though this isn't that kind of talk. We're happy to speak with you guys tonight to spread a little bit of high-quality information about breast cancer. As you probably are aware, it's Breast Cancer Awareness Month, so it seems like the right time to look at the scope of the problem, who's affected, what are the risk factors, what can we do about it, and then to spend some time talking about the exciting treatment advances that we have here at Lakeland, because we do have a breast program, I think, to be proud of. So for starters, what is breast cancer? Well, breast cancer is uncontrolled proliferation of ductal cells. If you look at the anatomy of the breast up there, within the breast, most of the connective tissue is this mix of sort of fatty tissue and some other protein elements, but also in there are ductals and lobules that are there to make milk. If you look at this diagram showing sort of progressive changes, the ducts are these tubes that normally have a thin layer of cells all the way around. Sometimes, for reasons that we only partially understand, these cells start to grow out of control. Now, when we say grow, we don't mean they get bigger like you inflate a balloon and it gets bigger. We mean that they are multiplying. So 2 become 4, 4 become 8. Before you know it, you've got a million of the darn things, and they look more and more abnormal, stack up on top of each other like this, and then eventually figure out how to get out of the duct and start dividing through the tissue of the breast itself. And once the cells can do that, then they have the ability to spread to other parts of the body and ultimately threaten the life of the woman, or much less commonly, the man. So that's what breast cancer is. Now, you'll also hear a term quite frequently called ductal carcinoma in situ. You can see that on the diagram, or maybe you can't because it is a little small, I apologize. But this phase right here is something called ductal carcinoma in situ, and you can see that the cells, they're proliferating, they're piling up on top of each other, but they can't get out of the duct, and that's why we treat ductal carcinoma in situ similar to cancer, but it is in truth a precancerous condition. It can't spread, it can't threaten the lives of women that are afflicted with it. This is a very rough and actually mildly inaccurate diagram related to the staging of breast cancer, but I just think it's useful to know, when we talk about cancer in general, you need to know the stage of the disease because the treatment options and our strategies and approaches are going to be somewhat based on the stage of the cancer. The earlier stage of the cancer, we may not need as many treatment modalities as we do for later, more advanced disease. I always say that the treatment for cancer is just like the story of Goldilocks. You want not too little treatment, not too much, just right. And similar thing, we need to know what stage the disease is to know how much intensity of treatment to bear. So in general, small cancers that are limited just to the breast with no lymph node spread are stage 1. You can actually have limited involvement and still have stage 1 and whatnot, and the staging system just changed, but rule of thumb, stage 1, slightly larger ones that still haven't spread to the nodes or early cancer spread to the nodes, stage 2. Significant lymph node involvement under the armpit, stage 3. And then stage 4, of course, is when the cancer has picked up and moved and started growing in other organs like the bones or the lungs or the liver, stage 4 disease. Now, most women, stage 1 through 3, we are trying to cure with our treatment. In other words, get rid of the cancer and have it never come back. That is a realistic possibility in virtually all of those women. Whereas stage 4 disease, there's only a very select few women where we can cure them if we're extraordinarily lucky. The rest we're trying to make the quality and length of life as long as we possibly can. This is why staging is important. You can see that the stage of the cancer dramatically impacts the projected survival rate into the future. And you can also see why we're so keen on things like mammography and screening, because in theory, if you are good at doing your screening, you're going to find a lot more cancers that are up here and a lot fewer that are down here. At least that's the hope. How big is the problem? Well, it's a pretty big problem. Breast cancer, if you ignore basal cell and squamous skin cancer, is by far the most common cancer in women, with over 250,000 cases diagnosed every year in the United States right now. Fully almost a third of female cancers are attributable to breast. And in terms of deaths, it's the number 2 killer. So it continues to be a very big problem despite the major advances and strides that we've made over the last 4 or 5 decades. Of course, other cancers on this list, lung cancer and pancreatic cancer, you sort of get a sense of how lethal those are, how much more mortality you get from a smaller percentage of cancers. But breast, in terms of overall numbers, remains a huge problem. One thing I wanted to address, though, right, every year we look at the number of cases and it goes up. So naturally, everyone assumes, oh my gosh, breast cancer is becoming more common, more women are being affected with it, more young women are being affected with it. You've probably heard things like this before, or because of what I call the Facebook effect, these things are now front and center in front of us. In 1983, if a 35-year-old got breast cancer, not everyone in their family circle and friend group knew about it, but that's how it is now. If we look at the incidence rates over time, it turns out that that's not actually true. This graph shows the rate of women per 100,000 diagnosed each year with cancer, and you see a bit of a steep rise after 1980. That was due to the introduction of mammography. It was also due to some degree to the effects of widespread use of hormone replacement therapy. But that peaked right around 99 and then fell some after most people stopped using hormone replacement therapy. And then I know this graph cuts off at about 2010, but the incidence of new cases is remaining flat. It's not changing very much. And in fact, the rate of disease in women under 50, the ones that many people think, oh gosh, it's becoming so much more common, has been flat since 1975. So even though there are more cases overall, because there's more population and because the population overall is aging, which leads to more cases of cancer, it is not, in fact, becoming far more common in this sort of dire scenario where we're all dying from pesticides and that sort of thing. This graph shows us what's happening to death rates from a bunch of different cancers, and we can see that since 1990, breast has been on a very nice, steady decline, along with lung cancer and colon cancer and most cancers, so we're definitely doing better. And one thing I like about this graph is to look at what used to be a huge killer, stomach cancer here, the black line. Back in 1930, stomach was the number 2 killer of women in the United States. And that's because it was pre-refrigeration for the most part. Right? Lots of foods were heavily salted and pickled and preserved in a way that stomach cancer was really common. We got rid of that and the rates fell. So that, to some degree, that makes people wonder, are there things in the environment that we could change that would radically alter our incidence and death rates from breast cancer? And we'll see over time, but we're definitely doing better. All right, so who is at risk? Well, first and foremost, when we look at risk factors for breast cancer, there's the ones you can change, and there's the ones you can't change. So the number 1 and 2 risk factors for breast cancer are being female and getting older. And the former you really can't change, and the latter you don't want to change because the alternative isn't so good. So those are the 2 things that influence your risk the most. You can see how much the risk changes just between a woman in her 50s and a woman over the age of 70. The likelihood of developing this goes up, and that's just a function of the fact that I think humans, I don't know if you believe in evolution or not, humans sort of designed to live about 40 years or so, and now we live far beyond that. And if you give our bodies enough chances to make a mistake, eventually it does it somewhere. In men, it's in the prostate, and women, it's in the breast. Other risk factors, well, there are things that we can control. So being overweight prior to menopause is actually protective for whatever reason. Nobody understands that. But after menopause, there's definitely an association with being overweight. And that has something to do with this other point down here, the sedentary lifestyle. These 2 things go together. Recent evidence suggests that a dedicated exercise program, vigorous exercise, 30 minutes a day, now that's a lot most people. But you can make a legitimate difference in terms of your risk of breast cancer by being healthy, exercising. You know, after menopause, that probably means a BMI under 24 or 25. And then other things, alcohol, we know that alcohol is not the best. Some studies suggest, 2 drinks is a cut point, but the reality is that there's probably no ideal or safe exposure. But then again, the air we breathe has all kinds of things in it, so you have to make certain decisions. But there is good quality evidence suggesting that more than 2 drinks a day increases your weight. And then synthetic chemicals. So this is what we don't know, but know probably isn't good. Things like parabens, hair dye. There's all kinds of stuff that we may ultimately discover was much worse for us than we thought. But I would say that the evidence for those things is still sort of in its infancy. So what about inherited risk? So, the breast cancer genes, the BRCA or BRCA1 and 2 are very well known from pop culture, the Angelina Jolie effect, if you will. And there are a number of other genes that if you inherit a gene that doesn't work properly, that's the problem with BRCA1 and 2. People inherit a gene that's responsible for certain types of DNA regulation. So they inherit a gene that doesn't work. And then they're at much higher risk for developing breast cancer or ovarian cancer or uterine cancer or colon cancer down the line. There's a number of different mutations that can cause very high risk, but they really do only account for a minority of cancers at the present time. The majority of cases are just, as far as we know right now, bad luck and a byproduct of age and all these other risk factors that we talked about. Women that do have these mutations have a very high risk over their lifetime of breast cancer. And that leads to different recommendations in terms of how these women are managed if they do have a diagnosis of cancer. It also leads to different recommendations in terms of how they are screened for cancer. Family history. So let's say you don't have one of these known inherited mutations that makes you susceptible. But if you do have if you're a woman who's afflicted, or a man for that matter, and you have multiple first-degree relatives that also have cancer, particularly if they have it at a young age, that dramatically increases your risk of having one if you haven't had one, or it dramatically increases your risk of developing a second one if you've developed the first.
Does that mean any type of cancer?
This is geared towards breast. Yeah. So the first degree relative thing is only for breast.
And is it only on the woman's side, the female's side?
For the most part, in this case, this bullet point is assuming that you don't have any of these known mutations. So in this case, yeah, the only risk is attributed to females.
She's asking maternal versus paternal.
I'm asking, both of those. Maternal.
No, if it's a direct blood relative, then the risk can be there. It doesn't have to all be maternal.
From your mom's side or your dad's side.
Yeah, exactly. So if your father's sister had breast cancer at the age of 40, that means something.
And so if you're adopted, you have the sex factor.
If you're adopted, then you just don't know.
Yeah.
Yeah. You don't know. This is a wonderful table that I expect everyone to memorize before you leave. No, but I think it puts a relative risk number, so you can see what's the big one. Age, right? We didn't put being a woman on here, but other big ones are things like RCA1 and 2, and then everything else is relatively less. And then things that are protective is breastfeeding, having 5 kids or more, exercise, a BMI less than 23, that's pretty low actually, and having ovaries removed before the age of 35. I think aspirin is controversial. I'm not telling everyone to go take aspirin, but it's just meant to be a summary slide. All right, so Dr. Jeffers, because she sees lots of women up front and I don't, is going to continue on talking about signs and symptoms of breast cancer.
Thank you. Hi, good evening. This is very loud. I don't know. All right. Yeah, that's going to feedback. Thanks. That's much better. Can you hear me? All right, great. Sorry for the pause in the presentation. Just wanted to make sure we didn't blow everybody's eardrums out. All right, signs and symptoms of breast cancer, different things that you could be looking for: a lump in the breast, or actually anywhere in the breast, which goes all the way up to the collarbone, all the way under the breast. Can also include anything under your arm, which is called the axilla. Any persistent or growing areas of redness, scaliness spreading over the breast, so that can come from the nipple area or anywhere else in the breast. Any persistent redness, you'd want to have a doctor check out. Any nipple discharge, it would be important to have that evaluated by your physician to see if it's something that could be physiologic or could be something worrisome or something to investigate further. A majority of early stage breast cancers are actually asymptomatic. What that means is they don't have any signs or symptoms. That's why screening mammograms and screening for breast cancer is important. Early detection is very important. As you saw from Dr. Gielda's slides, if we catch breast cancer in that early first and second stage, the overall mortality from that is very, very low, and the cure rate is very high. Death rate from breast cancer has been declining since 1989 due to improved methods of detection and early detection. Screening is performed with mammograms. Sometimes, in some situations, ultrasound or MRI are appropriate based on the patient's risk factors and other profiles and for their specific case. Mammograms can save lives because we can catch those cancers early before they've spread and hopefully treat that. Screening with an MRI has a role in women who have a lifetime risk of over 20%. This happens in people who have genetic mutations, such as BRCA mutation carriers, women who got chest radiation in their youth for like Hodgkin's lymphoma or other things like that, so if they've had radiation, or we have ways that we can calculate risk for women. So when you're talking about my aunt had breast cancer, my cousin has breast cancer, my grandma had breast cancer, we can put that in a risk calculator and look at each woman's her whole risk profile to determine what her lifetime risk is. And we do that to help then identify the best screening modalities for them and whether they would qualify for genetic testing and things like that. 3D mammography is another thing that we offer here at Lakeland. It's a newer modality newer way of acquiring a mammogram. It's available for patients with dense breasts. It can help us find subtle changes in the mammogram that may not be visible on a standard mammogram, especially with the women with dense breasts. What it does is it takes multiple slices or multiple images and kind of compiles those together to give the radiologist more slices to look through to see if there's any subtle changes. It tends to be more sensitive, which is kind of picking up those subtle changes. Screening guidelines. If you watch the news, you'll notice that there are multiple different kinds of screening guidelines from many different sources. Our goal here at Lakeland and as physicians is to help you and your primary care doctors determine what is the best screening guidelines to follow. As Dr. Gielda said, we have a breast program here, and our leadership team for that has reviewed all of the different guidelines, and we've talked about the pluses and minuses of different ones, but we are following the guidelines from the American College of Radiology, and I'm going to review those here with you. Our breast program is accredited by the NAPBC, which is the national, it's a national accreditation for breast programs, and it's put on by the American College of Surgeons. And our imaging center is also accredited by the American College of Radiology as a center of excellence. So we follow all of these guidelines to help provide the best care possible to the women. So screening guidelines for an average risk female, screening annually after 40 years old. So that's every year after the age of 40. If you have a genetic predisposition, recommend starting at 30 or 10 years prior to when your first degree relative had breast cancer, depending on if that puts you earlier than 40. Women who have a lifetime risk over 20%. And we talked about the chest radiation previously, as well as annually for diagnosis with high-risk breast lesions. So what that means is something that is an abnormality in the breast, but isn't cancer itself, but it puts you at high risk for developing cancer. So that is atypical ductal hyperplasia, and actually DCIS is erroneous here. It's actually LCIS, which is lobular carcinoma in situ, are both two of the big risk factor modalities that we do see in women. So those increase your relative risk of developing breast cancer at that area or somewhere else in your breast. So we want to screen those people more often. So we are an imaging center of excellence. What does that mean? So what that means is that the national guidelines want to make sure we're following all the rules, that we have good follow-up protocols for if something's normal, if something's abnormal, how do we communicate that out? And do we have the tools necessary to do the next steps to best care for women? And we do have all of those, and we've been evaluated for that. Things that we do have available in our imaging center are the 3D mammography, regular diagnostic or screening mammograms, ultrasounds, breast MRI are available here. So if you have breast cancer, what do we do? So you've had your screening mammogram, found a lesion, now you're diagnosed with breast cancer. I like to explain to women that there are 3 different areas of treatment that we look at. We look at surgery, we look at radiation, and chemotherapy, other hormonal therapies. So surgery with or without radiation is given to help prevent the cancer from coming back. So that gets rid of the original cancer. It can help us stage by looking at the lymph nodes under the arm, and it can help prevent that cancer from coming back. The radiation can be added in some situations to help boost that effect. Chemotherapy or anti-hormonal therapy can be given to help also prevent the cancer from coming back, but they can also be given if there's a chance that it spread somewhere, whether that risk is low because it just is a cancer in the breast at this time, so they have a risk of it potentially spreading later on down the line, or if it's metastasized at that time. So those modalities, and we use that treatment, all 3 of those treatments together, and as a patient is presented, we look at them, look at their whole history, look at all of their imaging, all of their clinical signs, and we come up with the best treatment plan for them. For breast cancer surgery, I like to explain that we have 2 choices. You have a partial mastectomy or lumpectomy, or you have a mastectomy, which is removing the entirety of the breast. So a partial mastectomy and lumpectomy are basically are the same things, just different verbiage to say the same thing. Basically, you're removing the area of the cancer and a rim of tissue around it. A mastectomy removes the entire breast tissue area on that side. When we do surgery for invasive breast cancer, we want to evaluate the lymph nodes. Sometimes lymph nodes, we evaluate them sometimes by ultrasound at the time that you're getting your imaging. Sometimes we would usually evaluate them by physical exam, by feeling. And then we also want to evaluate them pathologically, which is by doing a biopsy or removing a couple of those lymph nodes. How that works, it's called a sentinel lymph node biopsy. And what we've found is that if we inject a nuclear medicine dye at the nipple areolar complex, and sometimes use a blue dye as well, that will follow the lymphatics, or it's kind of like a water fluid channel that go up to the lymph nodes under the arm, and that will concentrate that dye, the blue dye or the nuclear medicine dye, in those first few lymph nodes. What that does is, I explain it, that it's kind of like the first line of defense for the lymph nodes under the arm. If there is cancer under the arm, it passes through there first and is found there. So that's why we want to check those lymph nodes to see if there's cancer there. And so that will help us with staging to best recommend further treatment to decide what to do next. If cancer is found in the sentinel lymph nodes, then it may be followed with further surgery to remove all the lymph nodes, or it can be followed with radiation therapy to the area. New studies have come out to indicate that we can actually eliminate that additional surgery, and in some cases, and use radiation. So rather than having surgery to remove the rest of those lymph nodes under the arm, we can treat that area with radiation. And what they have found with that is that you can reduce the risk of removing all of those lymph nodes, the increased risk and increased morbidity that comes with that. And also, some of the studies are even showing a potential survival benefit of using radiation. It's very close numbers, but it's still being investigated. But it definitely is similar treatment. So additional surgery under the arm can increase morbidity, can increase your risk of arm swelling and other complications, and some of that can be improved by choosing radiation. So what we have at Lakeland is we have a multidisciplinary cancer team that meets every week, and it's a team of radiologists, surgeons, radiation oncologists, medical oncologists. We also have our cancer navigators, which are nurse navigators who help our patients move through the system. We have social workers, physical therapists, a very wide variety of people who all work together we discuss the cancer cases, and then we as a team, a collaborative team, help determine what's best for the patients and look at their whole situation to determine the best treatment course for them. A few updates for our surgery modalities. One of the new things that we're doing here at Lakeland is that we're using a wireless localization technique. Another thing that we're going to talk about is oncoplastic reconstruction techniques, as well as skin sparing and nipple sparing mastectomies. These will be very brief. So, breast lesion localization has typically been performed with a wire localization. There's a new localization out that we're starting to use. It's called Savvy Scout. It's a radar technology. I'll go over those. So wire localization is a traditional localization with a wire. It's called either a needle or a wire. It's placed the day of surgery to locate the area where your biopsy had taken place. The wire comes out of the breast until it's removed and may not travel the shortest distance to the mass. So there's a lot of variability on how this is placed. Obviously, we try to make it the best as it can be, but there's some limitations to the technology. How that looks is, as you see here, with the breast with the wires coming out, the woman can have a lot of concerns with that, have a lot of anxiety and emotion related to this. The wireless localization, what it is it uses radar technology to locate a little reflector that's placed in the breast. The reflector is placed prior to the day of surgery. There's usually a lot less patient anxiety with the placement, as that is not part of the day of surgery. It improves scheduling flexibility for surgical times and decreases operating room delays, and is also safe for MRI or other imaging studies if you have that placed prior to getting other studies done. It's a small 1 centimeter device. It's about the size of a dime, and it just, as you can see here, kind of has like two little antennas and a little hub in the middle. It's placed either by mammographic or ultrasound guidance. And then there is a detector that we use in the operating room to detect that reflector, and that helps us localize the area of concern, especially if the area is not palpable. So if the woman has a palpable lesion or something you feel, a big mass, we would not necessarily need to use this, but this is for those smaller lesions that aren't able to be felt, that are found by mammogram, or calcifications, abnormal calcifications that you're going in to remove. This is how it can look, either under mammogram. You can see the little clip. Under ultrasound, we usually take a specimen radiograph after the procedure, and then on the MRI it can also be detected. Going to switch to the next topic, and that's oncoplastic reconstruction techniques. At the time of having part of the breast removed, sometimes we can utilize moving and mobilizing the surrounding tissue to fill that space where we've removed the cancer or the area of concern. And we do that to help keep the shape of the breast, to decrease any cosmetic deformities and things like that, to help women feel like their breast is normal. These Techniques also allow us to be creative, but yet purposeful in our incision planning, which is very important for the best cosmetic outcome. And it improves cosmetic results of partial mastectomy. Another area that we're advancing is with our mastectomies with reconstruction. Our surgeon team coordinates well with our reconstruction or plastic surgery team. Plastic surgery consults are offered at the time, anytime a woman chooses a mastectomy. Some women choose to have this and some women don't, and that's fine. If they do choose to have it, we do offer skin-sparing mastectomies, nipple-sparing mastectomies, depending on the location of the cancer and the whole picture there. And that leaves extra skin to help with reconstruction, to help with that, with the next surgical options. And that can be delayed or immediate reconstruction here. One of the other things I think I mentioned briefly is the NAPBC, and this is the breast cancer program, and it's an accreditation that's put on by the American College of Surgeons. And what they're looking at is they're looking at, do you have and provide things to your patients and your community to help women who have breast cancer or women who are at high risk or just regular breast disease, other benign breast things, and screening. So this is has very high standards. Do you meet that high echelon? And we do provide that standard of care here for you.
All right. Very good. So this is my favorite part of the talk, because this is where we get to talk even more about how, about the program that both Dr. Jeffers and I are very proud of. I think there's at times there's thinking in the community that Lakeland is a small community cancer program, and it's true that we're a community cancer program, but we're an extremely high quality cancer program, particularly breast cancer program, and staffed by physicians with the expertise and know-how to provide the very best and cutting-edge techniques, and also an administration that provides us with the tools to provide treatment that's as good as can be found anywhere. So I'm going to talk a little bit about radiation, what we offer with radiation here at Lakeland, what's new in radiation for breast cancer, and what kind of things are we excited about. So earlier, Dr. Jeffers touched on how surgery plus or minus radiation is used to keep the cancer from coming back in the breast and or the adjacent lymph nodes. And that's very important, and particularly in the setting of breast preservation. If less than a mastectomy is done, then the majority of women need radiation after that treatment, because if they don't, they're at a substantially higher risk of the cancer returning versus mastectomy. Whereas if you do the radiation, it wipes out that difference. You might wonder how that happens. And frankly, none of us know for sure how the surgeon can do a good surgery, take out the cancer, quote unquote, get it all, and then 40% of the time it grows back. But the truth is, after doing randomized studies with tens of thousands of patients, it happens. So radiation is an integral part of breast preservation. And then there are some women that need radiation even after mastectomy. And that's because even after removing the entirety of the breast and removing a bunch of lymph nodes sometimes, there's still a risk that the cancer can grow back along the chest wall, in the skin, usually along the scar, or in the lymph nodes that were left behind. Because we don't remove lymph nodes all the way up under the collarbone anymore, because that results in lymphedema too often. So that's radiation's niche, to increase the overall chance of cure, and doing it without increasing the risk of the woman dying from something caused by radiation. That's the trick. Oh, and the last thing, this is important. Having the breast off does not result in an overall better outcome in terms of cancer control or survival at any of the stages. And I think that's a sort of misconception that's out there. In fact, in stage 1 and 2, the data is not clean that shows this, but in early stage disease, women that have breast preservation with radiation may actually have better survival than women that are electing for mastectomy. But that's at the very least, it's not worse. Okay. So why do we need it? So I won't bore you guys with survival curves too much, but these are graphs of recurrence versus time. Time on the bottom, likelihood of recurrence. This curve up above is breast preservation alone, so just lumpectomy. This is lumpectomy and radiation. 15 years out, cut the risk in half. And these are older studies with worse outcomes than we have now, and that translated into a gain in survival. It was present both with node positive and node negative disease. Not to be outdone, even after mastectomy, these are 3,000 women with lymph nodes involved at the time of mastectomy. They strongly benefited. And you'll see that even after mastectomy, there was a risk of recurrence of about 30%, 10 years out. And if you received radiation, to drop that risk down into the single digits and ultimately decrease mortality. So this is why we recommend radiation in appropriate situations, because when done well, it does save lives and cures more patients. How's it done? Well, this is sort of what it looks like. If for left-sided cancer, in this case, breast preservation setting, we have this large machine called a linear accelerator. It costs $5 million. If you want to get one in your garage, you can't, because the state of Michigan won't let you. And it shines a beam right through the breast like a flashlight, like so. And the goal is to hit this breast tissue here. There's the stellate-looking cancer, but avoid all these goodies underneath, like the heart and the lungs and everything that we don't want to hit. How have things changed, and what are we doing to make things better at Lakeland and also across the state and across the country? Well, traditionally, for decades, breast preservation meant 7 weeks of daily radiation treatment, a long slog, a little bit at a time, day in and day out, which has quite an impact on quality of life and ability to work and a number of other important metrics there. We now know that most women who have breast preservation can receive a much shorter course of radiation. 3 or 4 weeks is sufficient for most of them. And not only is it just as good in terms of cancer control, it's probably better with respect to side effects. Now, there have been many people that are slow to adopt this, both in this region and others, and people that were slow to adopt this, some of the motivators are concerned about side effects, maybe, even though that's been debunked, but mainly it's this, because people get paid by the treatment, so it pays a lot more to do 35 treatments than to do 15. But it's been clear to us here that the short courses are better, and Lakeland's been a leader in the use of short course radiation. As long as I've been here, we've been we've been the top institution in the state in terms of using short course when it's appropriate, and even before I was here, that was the case as well, and I started doing that as soon as I got out of training. So we've been helping to push this forward, and many women have benefited from shorter course therapy. So one of the most widely available improvements these days in breast radiation is simply that it doesn't take as long much of the time. How else are we making it better? Well, it's safer than ever. We're far more accurate than we were in days gone by. In the old days, we would set up to tattoos and look at the light field and treat, but that's still probably safer than old radiation in other parts of the body, but there can be subtle changes in terms of where the breast is and where the underlying organs are that you're not necessarily appreciating, that we now appreciate because we take images every day to ensure that we're hitting exactly what we want to hit each and every time. It's been recognized that left-sided breast radiation is dangerous to the heart if you don't do it right. So we use something here called deep inspiration breath hold that dramatically decreases dose to the left side of dramatically decreases dose to the heart and can minimize the risk for heart-related complications 5, 10, 20 years in the future, heart attacks, congestive heart failure, all that stuff that nobody wants. And then on the right side, we can deliver radiation with the woman lying on her belly. That has many advantages because the breast hangs away from the chest wall. It lets us treat the breast without hitting really any of the lung underneath. So these are some of the cutting-edge delivery things that we have here that we've been pushing forward along with the other leaders in the field. So why does heart dose matter? Well, if you look at the dose to the heart and the risk of complications, you can see that as the dose goes up on the axis down here, there's a steep rise here. So it's really important to keep that dose down. This is an example of a patient on the left here. This is when she is free breathing. So you can see that to treat a classical field, the back of everything on this side of the red line is going to be radiated. And you notice that there's this little bit of heart that's in the field. But that's right at the apex. That's the part of the heart that squeezes. That's really bad. We don't want that. Well, that same patient, if she takes a deep breath, you can see, look, the cavity here is the same, right? That's the cavity from the cancer. There's the cavity from the cancer. There's a wire on Dr. Jeffers' cosmetically appealing scar. There's that same one. So we're in exactly the same place, but you can see that the heart looks different, and that's because the lungs fill up with air, it pushes the breast up, and now the breast is further from the heart. And now you can see that we can treat that breast without touching the heart at all. And this is what we do for every woman with a left-sided cancer, because we don't want to cause complications in the future. This is what it looks like from a beam's eye view. This was the initial one, right? There's that heart. We don't want that. Here's what we get after she takes a deep breath and holds it and we treat. So very effective. Where do we fall on this curve? Well, that's not really true. That's 0. It's because it didn't let me go down by 1. But we're so low that we're essentially on the line for 0 increase in risk. So if there is an increase in risk, it's less than 5%, and we're quite proud of that. We do as well or better than anyone in the state, and that's not just me talking. You know, we're part of consortiums so that we can see what everyone else in the state does, and that means Beaumont, U of M, Henry Ford, Spectrum, Grand Rapids, you name it. We're better than all of them, and we've won an award the last 2 years for being the best in the state. What about prone treatment? Well, this is an example of that. So here's a right-sided cancer. Everything that's bathed in color is getting radiated, and that includes this sliver of lung, right? So we don't want to radiate lung if we don't need to. Same patient lying down, breast falls away, now that sliver of lung sees nothing. And that's what it looks like. Usually the boards are pink. So both of these things, breath hold and prone treatment, let us dramatically decrease the risk to women that have to get external beam radiation for 3, 4, or even conventional courses, because some women still have to have full-length 6-week courses. The question is, can we do even better? Can we go shorter? And the answer is yes. Now, there's been interest in this. The last 15 years, there's been more interest in partial breast, treating just part of the breast instead of all of it, and don't have enough time to get into that debate. But there have been a variety of techniques, all of them very uncomfortable looking. You can see this one, needles through the breast. You're in the hospital for a few days with that. There's balloon-based ones where there's a balloon in the breast and it hangs out for 5 days. You get treated twice a day. This one looks like an egg beater when that comes out. Sometimes it's not the greatest picture. These methods all have problems in terms of comfort, infection rates, complications, and they're not really backed up by great evidence. They were immediately picked up by clinicians because they pay so well, but they're not necessarily better, unfortunately. This is protons. Protons for breast is just bunk. Protons have no benefit over conventional photons. So this is the partial breast stuff that was out there, and none of it's that great. So we have used these occasionally when there was a potential benefit to the patient and the patient was strongly motivated, but it wasn't the slam dunk that we were looking for. Now, intraoperative radiation is a form of partial breast radiation that is the ultimate inconvenience. Instead of running around with something hanging out of the breast for a week, you get all of your treatment, hopefully, at the time of surgery. It lengthens the procedure maybe a half hour, but you've had your surgery, you've had your lymph node tested, you've had the cavity where the cancer was, treated with radiation all at one time in your sleep, don't even know what happened. It's great, right? Well, the only problem is that if you do this in the wrong patients, or you do it with the wrong machine, the results don't look so good. This is an Italian study using this interesting looking machine here, where the risk of recurrence was was a tenfold higher at just 5 years versus traditional whole breast radiation. So intraoperative doesn't look so good if you don't do it the right way, but if you do it the right way, it does. So this is the Intrabeam device, and this is what we use here at Lakeland. This has an excellent randomized trial behind it showing that it's just as good as 6 weeks of treatment in the right patients. The way it works is this little part here is the business end, and later on there's a quick description of this procedure. I love how it talks about the radiation oncologist shaping the cavity. That's really funny. But really, Dr. Jeffers does all of this, and I'm just there for comic relief and to make sure that we don't treat something we shouldn't. This is the business end. This goes inside the patient, all under sterile conditions. The patient's asleep. We turn it on. It radiates the cavity for about 15, 20, 30 minutes, and then that's it. It's very simple. So, like I said, there is still concern. There's concern because if you use this in high-risk patients, the risk of recurrence is higher. So you can't do IORT on its own in a 45-year-old with triple negative breast cancer that's got a bunch of nodes involved. If you do that, you're asking for trouble. But in patients that are postmenopausal with hormone-positive tumors that are small and node negative, there's good data to say that the difference in risk between traditional treatment and that is only 0.2% at 5 years. So that's perfectly safe, and it certainly makes things a lot simpler. One treatment in the OR, better cosmetic outcome, cheaper, faster, more comfortable. It's better all the way around. So when can we use it alone? These are what we're using here as our criteria. We do sometimes use it in other settings in higher risk patients, but that's on trial in a different talk. This is just regurgitating what I just said. So, appropriate patients, it's great. And we have done more of these procedures than anybody in the state. We're the only other institution that has this aside from Beaumont. But at least right now, it looks like good treatment. Now, it could be that on 15-year follow-up in the randomized study that showed that this was good, maybe the data turns to looking not so good, at which point we'll stop doing this. That's part of the way that it works. But right now, it definitely looks good, and I think we're pretty happy with the outcomes thus far. And this is another diagram that shows sort of how it works. The surgeon scoops out the cancer during the lumpectomy, creates a cavity, puts in some sutures to draw the cavity tight around the applicator. I come in and perform the all-important ultrasound to make sure that it's far enough from the skin surface. We drape the patient like this down here. You can see there's all sorts of things going on here. And then we turn on the machine for the appropriate period of time. And then it comes out, and the surgeon closes things up beautifully, just like she or he normally would. So in summary, breast cancer remains a major public health problem, right? It's a big deal, affecting so many women and a small handful of men. The incidence rates are relatively flat, though. So that doesn't mean it's not a problem. It just means that it isn't as if things are spiraling out of control and getting so much worse. There are many things women can do to reduce risk, right? Most of them centering around healthy diet, exercise, and that sort of thing. Overall survival rates are pretty good, and we're looking to make them better. And survival rates in early stage disease are phenomenal. Again, so this is why screening is so important. We want to catch these cancers early. The best in terms of surgical therapy is available here, ditto for radiation therapy. The imaging center is a center of excellence. Medical oncology is great too. They're just not here, so they don't get to be spoken for tonight. But we still have a long way to go, right? We're not going to be happy until this 83% is 100%, and nobody has to have surgery, radiation, or anything anymore. You can either eradicate this completely or just take a pill and make it go away. It would be nice. We'll take questions in just a second, but before I say that, there is someone kind enough to be here in order to schedule mammograms if any of you are due. And with that, questions? Yeah?
How can a person go about getting genetically tested for risk factors? And who should that person be?
That's a good question. Do you want to answer that one?
I will. So I would recommend that if you have a strong family history of breast cancer, that you're evaluated by someone who can evaluate your risk and do that, look at that lifetime risk factor for you. And by doing that, that'll categorize you into different types of categories to see if you'd benefit from that genetic testing. Genetic testing can be offered by our medical oncologists. I do a lot of this as well, where I evaluate women who have a strong family history, and I go over their lifetime risk, calculate that with them, go over what is their screening protocol, and determine what's the best way to hopefully screen them, catch something early if it does develop, or in some situations get them tested for genetic mutations. I would say if you have a family member who is positive for a genetic mutation, or if you have a family member who had breast cancer early, they would be the best person to be tested first, because if they don't have it and they're the reason why you're at risk, then you're much, 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 much less likely to have it. And so that kind of a discussion could be had with a number of our team members.
That wireless implant that you were talking about, is that permanent once it goes in?
No.
The one for the surgery localization, that's removed in the surgical specimen at the time of surgery.
And what about nutritional support? Do you have anything like that for, to offset the radiation?
Yeah,
We do have dietitians and nutrition people
right, we have
on our
a
care
dietitian in
team.
radiation oncology that sees patients on a weekly, ongoing basis.
And the two types of radiation, the first one, with the beam that goes across, I take it that's more standard than that IORT.
That's correct.
And IORT is targeted at a specific group. Would it be, if you were in that specific group, would it still be better to opt out for the more standard radiation rather than, kind of take a chance on 15 years from now? Not that I'll be around 15 years from now, but just...
Well, I think that becomes a bit of a philosophical value judgment. I mean, the data really does look pretty good, I have to say. And I think that if you do fall squarely into the wheelhouse of the category of women that we're offering it to on its own, I think that subset, the results are very unlikely to change. I think that if you're at the periphery of that group, or where we're sort of bending the rules, which we really don't do, because I don't think it's a good idea, then there's a chance you really could be doing yourself a disservice. But I think, I've been very comfortable offering IORT, and I just couch it in, there could be a 2 or 3% difference in terms of local recurrence risk over the course of 5 to 10 years. We'll know more when the 10-year update comes out in the next year or two. But there also may be very little difference in appropriately selected patients. So from from an equipoise, from an ethical standpoint, I don't have any hangups at all, as long as the person is willing to wrap their minds around that. If you want the absolute lowest risk of local recurrence that you can have, then the answer is to have whole breast radiation.